Hello, and welcome to this Clinical Care Options podcast. I'm Nicola Hansen, Scientific Director, here with Dr. Genevieve Neal-Perry, who is Robert A. Ross Distinguished Professor and Chair of Obstetrics and Gynecology at the University of North Carolina School of Medicine, and Robin Martinez, a patient advocate who manages the online communities and patient engagement at Smart Patient. This episode of Cognitive Conversations will discuss HCP patient communication regarding brain health and cognitive decline, with a focus on OBGYN clinical settings. This podcast is part of our 2025 Brain Health Program in partnership with Practicing Clinicians Exchange, Smart Patients, and the Society for Post-Acute and Long-Term Care Medicine, and supported by an educational grant from Lilly. Please visit the show notes for a link to our Brain Health Resource Hub containing many additional activities. Now let's get started and hear what our expert has to say.
I'm Robin Martinez from smartpatients.com. We're a patient forum where people discuss peer-to-peer their interest in health, their problems with health, their questions about health, and we answer each other, and we also draw, of course, on the best of medical knowledge. So today we're talking with Dr. Genevieve Neal-Perry, who is in obstetrics and gynecology, and she often encounters women who, as they approach menopause or go through menopause, have questions about what's going on with their brain health. Is their brain fog normal? Are they having problems remembering because they're growing older, or because of hormones, or because of everything? And how scary is it? And so, Dr. Perry, could you tell us a little bit about how this comes up in OBGYN conversations?
Sure. And thanks for having us. I think it's a really important conversation. And from my perspective, knowledge is power. And really important thing is for us to empower patients so they can actually come to us when they have concerns and we can help them navigate what's the best path for them to take. So when I see patients, I often see patients who are either perimenopausal or menopausal. And the most common complaint is brain fog, right? They're having problems remembering things and feeling like they're not functioning at the level that they typically function. And you can imagine how unsettling and concerning this could be for someone who's, accustomed to multitasking and doing lots of things, who feels like, they can barely manage one thing. So that's typically the context in which patients present.
So, when someone comes in and they're getting a regular OBGYN check, how do they typically approach this issue, which sort of seems unrelated to OBGYN and yet really is very intimately related to it?
Yeah, and when you say intimately related, just to give context, is one of the most common complaints of people who are making that transition menopause and early menopause is just kind of this brain fog. And so what contributes to that? Hot flashes. We know that women who are making that transition into menopause have lots of hot flashes. They can have nighttime awakening and just a general sense of anxiety. All of these things can contribute to one's sense that you're not able to think as clearly and your executive functioning is not as high as you would typically have. And so the way that it, commonly presents it in the context of hot flashes, that a patient will come in with concerns of bothersome hot flashes, as well as concerns of just fatigue, and how that fatigue impacts, or I should say, in the constellation of symptoms, impacts their ability to really think clearly, feeling like they're not remembering things, and just feeling like they're not able to connect the dots the way that they normally do. And that's just
So
all
this So this is pretty common. What is your response as a doctor?
It's very common, upwards, depending on what you read, anywhere from 25 to 65% of perimenopausal and menopausal women will complain of this. The first thing that I do when I see patients is I acknowledge what they're experiencing because it is real. And oftentimes, patients are kind of sent about from one doctor to the next, and no one is kind of recognizing this constellation of symptoms for what it is. And so first thing I do is acknowledge it. And then the second thing I do is say, this will go away and it will be better. Because that's what they really want to know. Will this go away? Or is this going to be my chronic or, my constant state from this point forward? And that's always reassuring. That the symptoms related to the menopausal transition resolve and then get better. And it's not something that they have to live with for the rest of their lives. So those are the two things that I talk. And those are the two things I put on the table first. And then there's the inspired relief with that. And then we talk about, what are some of the most concerning complaints that they have and the things that might contribute to this general sense of brain fog and what the potential interventions are, both from the perspective of hormonal, non-hormonal, behavioral modification. So we approach it in a multi-pronged approach with really the patient's goals kind of at the top of the pyramid in terms of what they hope to achieve.
So one thing that we've discussed with other doctors in this is that general health helps with these specific problems too. Getting enough exercise, getting enough sleep, aiming for a healthy diet and a healthy weight, taking care of cholesterol problems, tending to diabetes correctly. All these factors of health play a role in addition to the hormones. Women are just lucky in having this hormonal problem added on to all the rest of it. So how do you differentiate? Is there a way to differentiate between how much of it is coming from being perimenopausal or menopausal as opposed to just general health issues? And how do you guide patients for that?
So that is a great question, and those are great comments. So when we think about kind of um, cognitive health, right? The ability to function and it's an executive functioning. We think about things that are preventable versus those things that are not. Those associated with the menopause, typically, like I said, they resolve. And if you can treat the hot flashes, you can reduce the sleep loss. There's some improvement, and women will absolutely come back to me and say, "Well, I sleep better, I think better." Then there are risk factors for cognitive decline that are separate from those typically associated with aging. Because as we all get older, we're not working at the same level as you would when you're 20. That's just a fact. Um, there are things like smoking. You alluded to diet and exercise. So people who have poor diets and they have higher cholesterol are going to be at risk for what we call cardiovascular disease. And this is a risk factor for cognitive decline. People who smoke and people who have diabetes. Again, these are things that can impact brain health as well as vascular health. Other things that we know can actually have an impact on cognitive function over time are problems with hearing. And so I do ensure that, we're having conversations, particularly as women are getting older, about whether or not they've had their hearing checked, because that's actually something to prevent. Other things that can negatively impact cognitive function over time is isolation. So ensuring that women have community where they're interacting with other people. It doesn't have to be family members, but as long as you have community and you're not isolated, we know that that reduces the risk for cognitive decline with age. Now, there's age related, that's associated with modifiable factors, and then there's genetic causes that will put people at risk for early dementia related with Alzheimer's, and then there's also a later onset. And those things are genetically, there's a genetic predisposition.
So a lot of patients um, have concerns about where their brain health might be leading. Uh, this is always something that's very frightening for people to go through. And it is reassuring to hear that if it's hormonally related, it's probably going to ease with time. What about all the other things like eyesight and isolation and things that a doctor may not be able to actually reach for the person? Uh, their difficulties, their difficulties with daily life, for example. Um, how do you interact with people who are telling you these problems? Do you refer them on?
Yeah, again, great questions. What I would like to start with, in terms of answering that question, these are conversations that should happen early on for risk is at its peak, all right? And so that we're informing patients about what are the things that they can actually modify themselves to reduce the risk for cognitive impairment. And you had mentioned, diet, things that we know can be associated with cognitive impairment that you can actually address would be vitamin B12 deficiency. It could be thyroid dysfunction. It could be uh, other uh, kind of hormonal or dietary interventions that you want to make sure that they're aware of and they're doing the things that they need to do. Similarly, making sure they're having their check, they're being checked regularly for diabetes, they're being checked for evidence of hypercholesterolemia, things that we know happen. In terms of, when do I refer as an OBGYN and a reproductive endocrinologist? If someone has a decline in function that is not consistent with what you might expect for someone their age, that is someone I'm going to send off. So they may report something, but if we do some tests, some office tests where you can assess kind of mental status, if it looks like everything is okay, I try to reassure and talk about things that they can do to try to improve kind of your daily functioning. If it looks like what they're reporting is consistent with what I'm finding with some of the objective tests, and that's a person I'm going to refer out. I'm going to refer them out to either a neurologist or some places have centers that are entirely focused on cognitive health. And so those are the kind of things that I will do. If someone has risk factors in their family in terms of risk for Alzheimer's, I'm going to get them connected earlier. We got to make sure that they've had any genetic testing that they need to have done, because there are some treatments that may actually kind of delay some of the onset of symptoms. So it's really, really important to have those conversations early on where that risk is highest. For patients who we are worried about in terms of their support, that's when it would be helpful to have a family member involved in the conversation, so that they understand what some of the risk factors are and how they actually may help mitigate some of the risks.
One thing that strikes me about women's situation is how often a woman will end up as an isolated widow. And this is something that a lot of gynecologists see. Uh, People who have lost their social network. They're no longer going to work. They're no longer involved as a child of young parents with school parents. They've lost their social circle that was related to socializing with their husband as a couple. Um, what kind of help do people like this need, and what kind of help can an OBGYN offer?
Yeah, it's for concerns like that, particularly if they're older, there are providers, geriatricians who really that is their expertise. Uh, their expertise is not just to take care of the high cholesterol, but to take care of all of the various aspects of a person who's aging. And so in situations like that, I am not shy about reaching out to someone who has expertise with coordinating multiple levels of care for these vulnerable patients. I do also encourage women, if they have the church, to be involved in their church. If they have a community, like a community where people come together to play games, for like small shows to really encourage them to do it. There are some community centers that really they realize that this is a challenge for 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 people as they age, and so they have shuttles to take patients or excuse me people from home to events. Some churches have shuttles. We're trying to help them identify communities where they're not isolated because that is a risk factor certainly for cognitive decline. And the other thing I worry about in those individuals are also ball injuries. Um, so really working with my community providers, my local community in terms of resources that are available for our aging patient or aging population to try to ensure that they're as connected as we can ensure that they're connected. When possible, I certainly encourage uh, aging women to live in communities where it's a community of aging individuals because they often have activities that are geared towards that population.
It's really hard for a lot of people as they age to change gears
Yeah.
and to realize maybe I shouldn't be living alone in this big house, or maybe I should move from my rural community to be closer to my children or grandchildren. And uprooting yourself at an advanced age is even harder than uprooting yourself earlier in life. Is there any guidance that doctors can offer to people to help them overcome this resistance?
Well, I would say change is hard, right? No matter how old you are. Um, and moving from a place that is familiar to one that's not, it's essentially hard. And that's why I said these kind of conversations should not start once someone has once they're encountering challenges. They really need to start very early or early on in kind of, when someone is not disabled or while they're still able to kind of really take control, yeah, of their environment. So I do think it's super important for families to have those kind of conversations much earlier. So they say, okay, if we reach this stage where you're not able to do X, Y, Z, here's the plan, right? So that there is no surprise and people don't feel like they're being uprooted without any real contribution to the discussion. Um, the best thing that a physician can do it's really probably, again, I can't stress about having the conversation early and many times so that when you are confronted, the patient is confronted with this situation, that that they're at peace with the decision and that they had a very active role in deciding what happens next, so that the patient feels in control, that they do have control over their lives. And that's one of the hardest things, feeling like you've lost control of your life. That would be why it's also very difficult to kind of uproot and move when you were not expecting to do so.
So you're saying that brain health is really a lifelong concern and a continuous concern that we should be dealing with from a young age, like not even thinking about retirement plans, but thinking about our futures and
Yeah,
go through different life stages. And
absolutely. Absolutely. Go ahead.
um, why is it so hard for people to realize this and begin thinking about it? It's as though in America, becoming 70 years old is suddenly a shock when you've been approaching it your whole life.
That is absolutely that is absolutely the case. And part of it is one, we kind of live in a society where um being young is kind of put on a pedestal, right? And aging is not always valued the same way as being young. That is just part of our culture. Um, in cultures where aging is, considered a really good thing, you see more community and you don't see quite the same thing. And so some of this is we have to change our culture, right, about how we think about aging. The other thing is that we do have to have these conversations earlier in life. And your comment about the continuum, that's absolutely true. Because if we're going to reduce the risk, we have to do things earlier in our lives, right? We shouldn't smoke. We should make sure we're exercising. We avoid things that can have an impact on our lives 30, years from now. And sometimes we just live in a moment, and it's good to live in a moment, but we have to also think about what the future looks like. And that's what we have to learn how to do. And we can do that. And as physicians, as providers, we have the ability to initiate those conversations at a time when it's not threatening and at a time when people have more agency and feel more empowered to actually make decisions.
Women and OBGYNs are sort of in a privileged position of having this special relationship that is in addition to having a primary care provider. Men don't typically have some doctor other than their main doctor that they have a lifelong relationship with. Whereas with an OBGYN, women might start when they start having their period and go through menopause and throughout their life with at least a gynecologist, if not their own gynecologist that they've had from a very early age. Um, do you feel that that's a special relationship between doctor and patient that can be utilized in maintaining brain health?
Oh, absolutely. It is a special relationship because you're seeing people throughout the continuum of their lives. So you can start having conversations when someone is in their 20s about things that can have an impact on their mental, on the quality of their lives later in life, as well as in terms of the risk for cognitive decline. And so I would say absolutely, it's an opportunity for both patient as well as the provider. You have that relationship, you have that trust to have conversations um, around mental health and cognitive health and how one could um, engage in activities that will give you a long runway of high executive function.
That's great. Thank
you.
you so much. This has been a really wonderful conversation. I very much enjoyed talking with you.
Well, thank you, Robin, and thank you for really focusing on um, cognitive decline and the things that we as providers can empower our patients with so that they can actually make changes that are meaningful and lifelong. So thank you.
Thank you very much, Genevieve and Robin. And thanks to you, the listeners, for joining us. Please look for 4 other companion podcast episodes discussing cognitive conversations in other clinical settings. As a reminder, to visit our full brain health resource hub, please click on the link in the show notes. As always, thanks for listening.